If everybody could take their seats, we're going to start with session number 2. And I'm just going to very briefly introduce Amanda Kleiman, a member of the board of ISAP and moderator for session number 2. Amanda's from UVA.
Thanks. It's my pleasure to moderate this session, which is entitled Anesthesia in the Environment, a really on-trend topic for us. Our first speaker today is Dr. Jeffrey Feldman. He's an attending anesthesiologist at the Children's Hospital of Philadelphia, as well as the University of Pennsylvania. He's a special interest in the use of technology in patient care and is a past president for the Society for Technology in Anesthesia. He also has a very keen interest on the environment and the effects of anesthesia on the environment. And his talk today is entitled Low Flow Anesthesia 100 Years Later.
Thank you. Thank you for the introduction. Good morning. Can you hear me okay? Good. So thanks for the invitation to be here this morning. When I was asked to give this talk, I had to really think hard about what my goal would be with this group, because there are a lot of experts on low flow anesthesia here. So, and typically the talk is teaching low flow anesthesia, but I think the motivation today, the goals are a little bit different in that we have this growing movement of interest in low flow anesthesia and a huge knowledge gap in the professionals that are providing anesthesia. And so I think we have two imperatives really that I would invite this group to think about and help with. One is, how do we get the education out there? And two, how do we promote the use of technology, which internationally is very available, in the United States, not so much, just beginning with GE's approval last year of end-tidal control. So a big part of my life a year ago was working on launching the course on low flow anesthesia through the APSF Technology Education Initiative. And I'm going to use that as the basis of most of my comments today, kind of talk to you about the thinking behind the course, some of the principles that we try to teach, definitely looking for feedback on that, as well as help promoting the course. I do want to recognize the people that have worked on that with us. The course was done in collaboration with Dr. Sem Lampatang and David Listus at the University of Florida in their simulation group. I had a world-class group of experts, Jan Hendricks, Jim Phillip, Ross Kennedy, all participated in developing the content. So I think we had as good a shot as we could. And I think the success, I'll give you some of the statistics at the end on the success rate. Just, let's see, this worked a moment ago. It is on. Advancing the slide. I might be a little too far from the receipt. Okay, well, let's see. Okay.
Yeah, that's you.
Okay, all right. So I do have a few consulting agreements. This presentation is almost completely devoid of particular companies or devices. Anything that does show up is not an intention to promote anybody, particular technology. Low flow anesthesia is not new. It's been around about 100 years. Ralph Waters published one of his first papers, 1924, maybe 1926, somewhere around there. And he really created the foundation for low flow anesthesia with the introduction of CO2 absorbance. And prior to that, anesthesia was given by open delivery. So they had a lot of problems that he was trying to address. And this is the canister that he pioneered. This is the first use of CO2 absorbance clinically on a regular basis in the operating room. Mask, bag, a place to insufflate oxygen and anesthetic agents. And I think this work is really fascinating because they had no pulse oximeters, they had no end-tidal agent concentration monitors, barely had physiologic monitors, but they really understood the safety implications of what they were doing. And this quote comes from the paper in 1926. The signs of oxygen want and plane of anesthesia are shown by color, muscular phenomena, etc., and must be watched constantly. And this really underscores a really important theme of the course, as you'll see, which is the need to monitor when you do low flow anesthesia. It's not an automated process. You need to look at oxygen concentration. You need to look at anesthetic concentrations in order to do it effectively. In 1936, he reported their experience over quite some time, over a decade, 20,000 plus anesthetics, safely administered. They talked about a reduced fire risk because there was no more open delivery of flammable anesthetics and oxygen, reduced staff exposure in the operating room to gases, reduced cost. They were able to take the cost savings and actually use it for other things, and improved maintenance of normal physiology because they could keep a moist atmosphere in the patient's lungs. And so really stunning accomplishments and really set the foundation for the practice opportunity we enjoy today. So now, I think the mantra is it takes about 17 years to get something from publication to practice. We're about 100 years on now, and we're still struggling with it a little bit. But in the 21st century, our impetus for low flow anesthesia has changed a little bit. We know now that the anesthetics we administer have a profound impact on the environment. So every anesthesia professional, when they turn out on that vaporizer, has some responsibility to think about their impact on the environment. It's not the local environment that we're talking about that Waters was concerned about, but now the global environment. There are still patient benefits. It does preserve heat and humidity to lower fresh gas flows, although arguably we have heat and moisture exchangers where we can manage that to some degree. We can reduce waste, and I think it's especially important, and we'll talk about this a little bit later as well, that not to increase fresh gas flow when it doesn't provide any clinical benefit. That's really just pure waste, and I see a lot of that going on in my hospital even now. Interestingly, cost reduction is an opportunity to reduce costs, but it's just not a burning platform in the Western world, from what I can tell. It's not a pharmacy talks about saving costs. People talk about saving costs, but since the anesthesia professionals aren't swiping their card at the end of the anesthetic to pay for the gases, it's not really a motivator. This is, I don't know. There we go. So this is the course, and let me just see if this is going to work. Yeah, okay. So you'll see the simulation start to run. So what we did with the course is a guided simulation, and we tried to simulate a generic circle system to really give people the notion of what's happening inside the machine, because I think it's a mental model that people struggle with a little bit. Under the hood are models for uptake for oxygen and anesthetics. So as people change the dials, they can see what the impact is going to be. It's a simulated adult. You can't change the patient's size like you can with Gasman. There are thresholds for minute ventilation and oxygen consumption that are fixed, but it does allow someone to really explore the principles. One of the things I really like about the graphic is the way we displayed rebreathing. So you see the little circles here, and the ones that have the extra halo are expired from the patient. And so now we're at a fresh gas flow of 1 with about 80 to 90% rebreathing. And you can see with the breaths that the exhaled gases are returning to the patient. So now you can actually help someone visualize what it means when you talk about rebreathing and the relationship between fresh gas flow and rebreathing. And the goal of our course was not really to tell people you should use a fresh gas flow of X. It's just to give them the knowledge to start to comfortably reduce their fresh gas flow. So whatever you're using today, tomorrow, turn it down a little bit. Think about what you learned. The next day, maybe turn it down a little bit more. And along with that, we really thought about what the definition of low flow anesthesia would be. And this is just, there we go. And so it's really not a number because it depends on the phase of the anesthetic. In the very beginning, as we've seen from some of the earlier talks, reducing the fresh gas flow will give you an inadequate anesthetic concentration. So the definition we arrived at is the practice of reducing fresh gas flow below minute ventilation to the lowest level consistent with equipment capabilities and provider comfort, while ensuring safe and effective care for the patient. And I think the underlying parts of this definition really speak to the key principles, which is one, you want to get below minute ventilation so you get some rebreathing. If you don't do that, you're not taking advantage of the circle system. Equipment capabilities make a difference. Some machines will allow you to get lower than other machines. Provider comfort is essential. You just don't want someone to be operating in a place that they don't want to be operating. And finally, ensuring safe and effective care for the patient, of course, is paramount. So at the bottom of all the slides, I have this definition of efficiency, and it repeats for every slide because I think it's really the underpinning concept, which is the efficiency of your inhalation anesthetic is what the patient needs divided by what you deliver. And we heard some of that earlier today. And so if you deliver way more than the patient's going to take up, your efficiency is going to go way down. So how do you begin to match that? How do you adjust your flows so you can match that? Well, it turns out we have kind of known how to do that for a long time. Closed circuit anesthesia's been around for a while. I'm sure many people have dabbled in it, if not used it on a regular basis. It's the injection of anesthetic directly in the circuit, tailoring oxygen delivery to exactly what the patient consumes. Nothing goes out the scavenging system. And this is a screenshot from the Gassman workbook on closed circuit anesthesia. And by this definition of efficiency, this is about 68%, not quite 100%, but this is just about, I think, 15 minutes into the anesthetic. So we have a circuit concentration that's above the concentration in the body. And so I think that speaks to the fact that it's not quite 100% efficient as time goes by and the circuit concentration matches the body concentration, efficiency is going to go up. So closed circuit anesthesia is kind of the answer, but in the absence of some of the machines that inject anesthetic directly, nobody really does this on a regular basis. It's just too hard to do. But it is possible with a vaporizer to do closed circuit anesthesia. This is a case from some months ago that I was doing with one of the fellows. And you can see that our oxygen flow is set to match oxygen consumption. We have, can't quite get this thing to, no, there we go. So we've got oxygen concentrations and anesthetic concentrations about the place where we want them. We're basically adjusting oxygen flows to keep the oxygen concentration stable. We need to set the vaporizer a good bit higher in order to achieve that concentration. And you can see also that there's some inspired CO2, which speaks to the fact that we're consuming the absorbent not quite at the threshold where it would need to be changed at this point. And it turns out that maintenance of anesthesia is relatively easy. So this is because the uptake is a lot slower. So things are happening more slowly. And so in this simulation, this is an hour anesthetic at 1 liter per minute, and arguably not the lowest possible flow you could get, but it makes the point that you have a little higher vaporizer concentration than your actual expired concentration. Oxygen concentrations higher than what we're seeing in the inspired. And so it's a typical sort of lower flow maintenance. But you can go wrong if you're not careful. And so monitoring is essential. And so here we have the same anesthetic, 1 liter per minute at 30 minutes. And you can see that the vaporizer, in this case, the vaporizer concentration was not increased after the induction. The delivered concentration stayed the same. And so the expired anesthetic concentration now is starting to fall, maybe getting a little bit lower than we like. And the oxygen changes are a little more insidious because it happens slowly. And at 30 minutes, we're kind of still in an okay range, but you can see you're going to be hypoxic before too long. So monitoring as you try to reduce your fresh gas flows, as we all know, monitoring is essential, and adjusting oxygen and anesthetic to ensure that you get the right inspired oxygen, expired anesthetic concentrations, key. So maintenance relatively easy, and that's great. But it turns out that maintenance isn't good enough if you really want to improve your efficiency. And I did want to kind of let these run. These are Gassman simulations. Okay, that's one. Yeah, and yeah, they're both running. Okay, oh, nope. Struggling with the pointer here a little bit. Anyway, I'll see if I can get them to run. If not, the point is that both of these are maintenance anesthetics for about an hour and a half anesthetic, where 1 liter per minute is used for the maintenance phase. But on the one on the left, the induction is done with 8 liters per minute of fresh gas flow, well above minute ventilation. And the emergence is done by increasing the fresh gas flow and then progressively reducing the vaporizer concentration. On the right, the induction is done with 4 liters per minute, so matching minute ventilation so that there's no rebreathing. And as we'll see in an example a little later on, the emergence is done by turning the vaporizer off, keeping the flows low, the coasting concept that Andre and Jan have published a lot on. And so the efficiency changes quite dramatically if you manage your induction and your emergence effectively. And so maintenance doesn't quite get you there. And I think that's one of the harder concepts to try to teach here, is to get people to learn how to manage their induction and their emergence so that we really conserve anesthetic during those phases, because you can blow it during induction and never really catch up during maintenance. All right, let's see if I can get things to go here without going too far. The animation is not quite right, but there we go. Okay, so I did a little thought concept of whether or not you could do a closed circuit induction with a vaporizer, because that would be the ultimate, right? You set your fresh gas flow from the outset to match oxygen consumption. And then I use the unit dose calculation that you use in closed circuit anesthesia. So in the first minute, for example, of sevoflurane, and this is size adult, you'd need to give about 63 mLs of sevoflurane vapor. But in order to do that at 210 mLs per minute of oxygen flow, you need to set the sevoflurane vaporizer at 30%. So obviously that's not going to happen. And then, out to 4 minutes, you need to be out at 10% from 1 to 4 minutes to get the next unit dose in. And you have similar challenges with desflurane and isoflurane. So, you're out quite a bit into the anesthetic before you can actually induce the patient properly with a vaporizer and maintain the flows. So you have no choice. You have to increase your fresh gas flows during the early phase of the anesthetic. Question is, how long do you have to increase your fresh gas flows? When can you reduce them? How can you make changes? And so that's a key concept that we're trying to teach in the course. Actually, before I get into that, though, okay, so just to emphasize, this rebreathing is a key concept, and so we do try to emphasize that. And all right, I'm going to pass through this slide because I think this group gets the idea. But basically, that's what that simulation is intended to show, is when you reach a certain threshold for fresh gas flow, increasing it further creates waste with no clinical benefit. So this is a simulation comparing a 10 liter per minute induction to a 5 liter per minute induction. So it's pre-oxygenation for 5 minutes without inhalation anesthetic, and then you turn on the anesthetic. And you compare 10 liters to 5 liters per minute, and you can see the expired anesthetic concentration is marginally different. And we saw this actually in Jim's example also earlier. And that small difference relates to the rate of mixing in the volume of the anesthetic in the anesthetic machine, but it really doesn't marginally change the dynamics in the patient or the kinetics in the patient. So there's never really a reason to exceed minute ventilation. So in Jim's example, it was 3 liters per minute. In our simulation, minute ventilation set at 5 liters per minute. It's a rule of thumb, but it's a good place to start. And again, monitoring the rate of rise of inhaled agent concentration can help you determine if you've hit the mark or not, if you're getting an adequate fresh gas flow for induction. So we try to explore the induction strategy a little bit more in the course. And so this is a simulation. It's showing, again, 5 minutes of pre-oxygenation and then a 3-minute induction at 5 liters per minute with no rebreathing. And then at the, 3 minutes of induction at 5 liters per minute. And then at the 3-minute mark, we lower the fresh gas flow to ½ liter per minute and turn the vaporizer up to 5%. And so you can see we're getting adequate concentrations as we would expect after 3 minutes of fresh gas flow at a high fresh gas flow. And then the question is it sustained? And so this is now out to 15 minutes. And you can see that ½ liter per minute from 8 minutes out to 15 minutes, again, sustains the anesthetic concentration pretty well. Oxygen is starting to tail down, as you would expect. And we've reduced now the vaporizer because we're starting to see a rate of rise here of anesthetic concentration. And so it gives people the insight, hopefully, to begin to think about how to manage the dynamics of oxygen flow, anesthetic vaporizer setting, and then what they're going to see clinically on the monitors. So these are the plots of anesthetic concentration and oxygen for that same simulation. And you can see when you compare keeping the fresh gas flow high to reducing the fresh gas flow, we can get pretty much the same exhale anesthetic concentration. This little blips reflects the need to change the vaporizer to keep this from rising in that period of time. And oxygen also kind of settles out FI into about the same range with both methods of induction. And I didn't emphasize it in the last slide, but we also show the amount of anesthetic waste going out the scavenging system so people can get a sense of how much they're wasting with different strategies. And okay, so this is emergence. And what we tried to do here is compare two ways of emerging the patient. One, by raising the fresh gas flow, reducing the vaporizer progressively. The other by turning off the vaporizer, leaving the flows low. And so in this case, this is using the vaporizer for emergence. So at 1 hour into this anesthetic, basically we increase the fresh gas flow to 5 liters per minute, and we reduce the vaporizer setting. And as you'd expect, over the next 15 minutes, the agent concentration falls, the oxygen concentration rises, we're at 100%, and we're kind of ready to finalize the emergence by turning off the vaporizer completely and washing out the rest of the anesthetic. So alternately, we can, if the slide changes, that's the, this shows the key point here of this type of, again, it's not changing, but what you can see here is between 1 hour and 15 minutes, we're getting a continued accumulation of anesthetic vapor during that time because we've got the vaporizer on, basically. So we're continuing to deliver anesthetic during what we're trying to do is when we're trying to emerge the patient. The alternate strategy that you can play around with the simulation is at 1 hour, you turn off the vaporizer, leave the fresh gas flow low at 0.5 liter per minute, and 15 minutes later, we're about at the same place with anesthetic and oxygen starting to rise a little bit more gradually. And the agent waste that's depicted here is really just what's being exhaled by the patient because no additional anesthetic is being put into the circuit. And then with the plots, people can see here that in the previous simulation, the dotted line shows the continued accumulation of anesthetic, whereas there's no more additional anesthetic coming into the circuit there. So again, teaching principles, trying to empower people with the knowledge to change their practice in a meaningful way and reduce the amount of anesthetic that's released into the environment. So there are a lot of barriers to practicing low flow anesthesia. And, we try to address the safety concerns about oxygen delivery and anesthetic step by emphasizing the need for monitoring. There was a question earlier about the sevoflurane. I don't want to get into it now, but it's basically medically obsolete. There's a lot of publications about it. You don't have to worry about sevoflurane and low flows with sevoflurane. There can be some equipment limitations, and the big issue really is the slow rate of change of circuit concentration. So everything happens really slowly. So even though you can teach people to lower their flows, raise the vaporizer setting, it doesn't happen right away. So typically, I'm starting to use my alarm limits a fair amount, particularly with the trainees. So if I'm a little concerned about adequate oxygen delivery, I'll set the lower limit at 25 or 27%. So there's a little tap on the shoulder before it becomes something dangerous. And you can do similar settings with agent concentration. So in some way, I wanted to throw this in because TIVA is so near and dear to the hearts of this group. And in a lot of ways, low flow and TIVA are similar in that both require kind of tapering the drug delivery over time to reflect the uptake by the patient. really low flow should be easier than managing a propofol TIVA because you have MAC guidance in real time on the machine. You're measuring the agent concentration on a breath-to-breath basis. It's really easy to correct an overdose, but the problem is when you give too much anesthetic, it's scavenged and no one sees it. When you give too much of this one, you see it immediately because the patient gets hypotensive and that sort of thing. So I think that's the difference that probably makes this a little easier to manage at the bedside in some ways than really hitting low flow right. So there are a few key technology requirements that make a difference. Obviously, you have to have an oxygen agent analyzer. Having a return of sampled gas to the circuit is really helpful. It allows you to drive your flows even a bit lower. You want to obviously have a minimal leak circuit. I've had questions about the use of supraglottic airways and leaks around the supraglottic airway. I do a lot of low flow. The case that I showed earlier was a patient with a supraglottic airway. So as long as you have a good fit, I think it's fine. And then just like technology tools have helped to foster TIVA, with TCI, there are technology tools that are useful for low flow anesthesia. And I'm not going to spend too much time on them because I know there's an international audience. A lot of you know these tools very well. If I can't advance the slide, it won't help anyway, but okay, thank you. I'll point to you. So the technology, I think, falls into 4 categories. Oxygen anesthetic and concentration monitors are essential. And then what you see in the machines are oxygen uptake-based tools, and we have those for the most part in the United States. Every manufacturer, econometers, optimizers, low flow wizards, they're all oxygen uptake-based tools that give you a little guide on how low you can set your fresh gas flow. Prediction tools that predict where oxygen anesthetic is going to go, and then closed loop controllers. So go ahead, next slide. Oxygen uptake-based tools basically estimate oxygen consumption based on measured FiO2 and FeO2 by minute ventilation, and then helps that to use that as a guide to the minimum flow setting. I think one of the big limitations of those tools is that they don't really consider the anesthetic concentration at the time. So they're not useful for induction, really only useful for maintenance of anesthesia. And some include oxygen concentration, some don't. There's a lot of manual control still by the user, but they're useful for maintenance. And I think also for emergence on that second strategy that we talked about, where you leave the flows low, turn off the vaporizer. Next slide, please. Prediction tools, unfortunately not in the US as of yet, but I think those can be really useful to help guide the clinician to settings because it'll show you what your future concentrations of oxygen and anesthetic are. They're very well established. They work well. I wish we had them. They use models of oxygen anesthetic uptake. You do need a more sophisticated vaporizer. The classic mechanical vaporizer is not going to cut it for those tools. So there's a technology requirement, but it's useful in all phases of the anesthetic. Closed loop control tools, really, that's the holy grail for those of you out there that have used them. I'm sure you enjoy it quite a bit, but it really automates all of this stuff that we're trying to teach that's really challenging to teach to practitioners. Next slide. So take home messages. I really try to tell the trainees that you're the ones that are going to control how much waste goes into the environment. You turn the dials, you adjust the fresh gas flows. It's your practice that's going to create pollution or not. Try to really emphasize not going above minute ventilation with fresh gas flow. There's no reason to do that. Monitoring is key. And hopefully we'll get some of the technology tools in the future. Next slide. So this is the course. There's a landing page on the APSF website. The course is actually in the ASA learning management system. They had the foundation for delivering the course. So on the APSF website, we have some backup articles and that sort of thing. The course is available free of charge to any anesthesia professional. It generates CME credits. We tried to reduce that as a barrier. Next slide. And so it was launched a year ago at the ASA, and these are the statistics to date. There's almost 1,200 people have enrolled. 556 have completed it to CME credits. These are some of the many actually really great gratifying comments that we got from people about the course. It seems to be really well received. I think the people that are taking it are learning from it. And I've been trying to promote it for every CA1 resident in the country because I think they'll understand the anesthesia machine for the rest of their career. We're not there yet, but hopefully we'll get there, and you can, those of you in training programs can maybe help with that. Next slide. I think I'm about done. So it's a easy link to find it on the APSF website. And just as another plug for our technology education initiative, at this meeting, we're launching a course on quantitative neuromuscular blockade monitoring. It's also going to be guided simulations similar to this format. And we're planning another course. It'll either be 1 or 2 years, depending on the scale, but we're going to try to keep it going. And any ideas you have for technology education, I'd be happy to hear it too, and float it to the group. Thank you so much for your time today.
Questions for Dr. Feldman? You can also ask questions at the end. Our next speaker is Dr. Owen Colmer, who is joining us virtually today. Dr. Colmer is an anesthesiologist and a PhD in biomedical engineering at the Ghent University in Belgium. Among his broad range of over 80 publications in the field of anesthesia, he specifically published on the environmental role of inhaled anesthetics, the occupational risk of using them, and their clinical use. His topic today is entitled Climate Impact of Volatile Anesthetics, Vital Insights for Anesthetists in the Era of Climate Change.
Well, thank you for your introduction. You can hear me, I hope?